If you take amlodipine every day and think you already know everything you need to know about it, this video is going to change that. Because there are 5 specific things that interact with this medication in ways that are completely predictable, thoroughly documented, and almost never discussed at the point of prescription. And the odds are high that you have done at least one of them this week without a second thought. This is not about rare reactions or unusual sensitivities. This is about ordinary, everyday things. A fruit, a painkiller, a decision made at home, a long wait in a queue that quietly alter how amlodipine behaves inside your body in ways that can produce symptoms serious enough to send people to hospital. Not because amlodipine is dangerous on its own, it is one of the most widely prescribed and well-studied blood pressure medications in the world, but because the way it works makes it specifically vulnerable to 5 things that nobody thought to mention when it was handed to you. The appointment where amlodipine gets prescribed usually covers 3 things: the dose, the purpose, and maybe one side effect if there is time. What it almost never covers is what happens when amlodipine meets grapefruit, or an over-the-counter painkiller, or a decision to stop taking it because of swollen ankles. Each of those 5 things individually sounds harmless. Together, or even alone under the wrong conditions, they account for a significant proportion of amlodipine-related complications in adults over 60. Stay with me through all 5 because the 5th one connects directly back to the first 4, and once you understand it, you will think about all of them differently. Before we go any further, do not stop, reduce, or change your amlodipine dose based on anything in this video without speaking to your prescribing doctor first. Everything here is information to take to your next appointment, not a decision to make on your own. 5 things. Let's go through every single one. The first thing is grapefruit and grapefruit juice. This sounds like the kind of warning that gets printed on inserts nobody reads. But the mechanism behind it is real. It is significant, and most people on amlodipine have never had it explained to them properly. Amlodipine is broken down in the liver by an enzyme called CYP3A4. Think of this enzyme as the exit door through which amlodipine leaves your body after it has done its job. The problem with grapefruit inks, and this applies to whole grapefruit, grapefruit juice, and any drink listing grapefruit as an ingredient, is that it contains compounds called furanocoumarins. These compounds do not slow down the CYP3A4 enzyme. They do not temporarily reduce its activity. They irreversibly inhibit it. They lock the exit door. When that exit door is locked, amlodipine cannot leave your system at the rate it was designed to. It accumulates. It builds up in your bloodstream at concentrations significantly higher than your prescribed dose was ever intended to produce. Research has documented that a single glass of grapefruit juice can increase amlodipine blood levels by anywhere between 30 and 90%, depending on the individual and the quantity consumed. That is not a small shift. That is the equivalent of taking a substantially higher dose than your doctor prescribed without either of you knowing. The symptoms of this accumulation look exactly like the side effects listed on the package insert: dizziness, flushing, palpitations, headache, ankle swelling. And this is where it gets important. A significant number of patients who have been told they are simply sensitive to amlodipine or who have had their dose reduced because of these symptoms were not experiencing sensitivity at all. They were experiencing the effects of an unintended dose escalation driven entirely by a daily glass of grapefruit juice. The same interaction applies to Seville oranges, the kind used in marmalade and some juices. Sweet oranges, lemons, and limes do not contain furanocoumarins and are completely safe. If you are taking amlodipine and consuming grapefruit in any form, stop today and speak to your pharmacist. This same CYP3A4 interaction affects many statins and other common medications, so a full review is worth having now rather than waiting. That is the first thing. The second one is the interaction that your instinct will almost certainly tell you is the safe choice. And in this specific case, your instinct is wrong. The second thing is stopping amlodipine abruptly. Amlodipine works by relaxing the smooth muscle in your arterial walls, keeping those arteries in a more dilated, open state than they would naturally maintain on their own. Over weeks and months of consistent use, your arterial smooth muscle adapts to this state. It adjusts to the presence of the medication. It recalibrates around it. And that recalibration is precisely what makes stopping suddenly so much more significant than most people realize. When amlodipine is stopped abruptly, whether because of a side effect, a decision to try without it, a prescription that ran out and was not refilled promptly, or even just a week away from home where the tablets were forgotten, the arterial smooth muscle does not simply drift back to its original pre-treatment state. In a meaningful proportion of patients, it overshoots. It constricts more tightly than it ever did before the medication was started. This is called rebound vasoconstriction, and the blood pressure surge it produces can be more extreme than the blood pressure the person had before they ever began taking amlodipine. The analogy that makes this clearest is a spring that has been held in a stretched, extended position for months. Release that tension suddenly, and the spring does not gently return to its original length. It snaps. It contracts past its resting state before it settles. The arterial smooth muscle on amlodipine behaves the same way when the medication holding it in its extended state is removed without warning. This rebound effect can begin within 24 to 48 hours of the last missed dose. In adults with existing cardiovascular risk factors, the surge in blood pressure during this window carries genuine risk of stroke and cardiac events. And the patients most likely to stop amlodipine abruptly are often those who stop it precisely because they noticed a side effect and decided to manage it themselves, which brings us directly to the fifth thing on this list. But we are not there yet. If amlodipine needs to be stopped for any reason, that decision should involve your prescribing doctor, who can advise whether a gradual taper or an immediate substitute medication is appropriate. Never simply stop and wait to see what happens. The window where you are waiting to see what happens is exactly when the rebound risk is at its highest. The third thing is one that almost no one has ever connected to their blood pressure medication at all, not because it is obscure, but because it involves something completely ordinary: standing still. Amlodipine's vasodilation effect is not uniform across the entire circulation. It preferentially dilates the small arteries feeding the capillary beds in the lower limbs, the legs and feet, more than it dilates the veins that drain blood back up from those same areas. Under normal conditions, when you are walking, the skeletal muscles in your calves contract with every step and act as a pump that pushes venous blood back upward toward the heart. This is called the calf muscle pump, and it is a critical part of how circulation stays balanced in the lower body. When you are standing completely still, in a long queue at the post office, at a checkout, during a church service, while working in the garden without shifting your weight, that calf muscle pump is switched off. Blood is flowing into the capillary beds of the lower legs through those dilated arteries, but nothing is actively returning it. Combine amlodipine's preferential arterial dilation with the absence of the pump that compensates for it, and blood pools in the lower limbs faster and more significantly than it would in someone not taking the medication. This produces two consequences. The first is the worsening of ankle and lower leg swelling during and after prolonged standing. Distinct from the baseline swelling some people experience simply from taking amlodipine. The second, and more important, is what happens when a position change occurs suddenly after that pooling has been going on for a while. Standing up to walk after a long service. Moving sharply in a queue after waiting motionless for 20 minutes. The blood that has been pooled in the lower limbs redistributes abruptly, and in susceptible adults, particularly those who are also mildly dehydrated, on more than one blood pressure medication or prone to orthostatic changes. This redistribution can produce a transient but significant drop in the blood pressure reaching the brain. The result is lightheadedness, and in some cases, fainting. Think of it like a dam where the inflow channel has been widened, but the outflow pump has been switched off. Water accumulates. When the pump is suddenly switched back on by movement, the redistribution happens faster than the system can compensate for. What to do instead is straightforward. If you know you will be standing still for an extended period, flex your calves regularly, shift your weight from foot to foot, or take a few steps every few minutes. You do not need to pace continuously. Even brief periodic calf activation is enough to keep the pump running and prevent accumulation. And if you do need to move suddenly after a long period of standing still, take a deliberate moment to pause with your hand on something stable before walking. That brief pause gives your circulation the seconds it needs to redistribute before the demands of walking begin. Have you ever felt lightheaded after standing for a long period and then suddenly moving? Think about that as we go into the fourth thing, because the mechanism behind this one is completely different from everything described so far. It is not an enzyme interaction, not a rebound effect, not a circulation pattern. It is a direct chemical interference with the core mechanism amlodipine is using to do its job. And the substance responsible for it is sitting in almost every medicine cabinet in the world right now. The fourth thing is regular NSAID use. Ibuprofen, naproxen, and the rest of this family of anti-inflammatory medications are among the most commonly taken over-the-counter tablets in existence. For joint pain, back pain, headaches, general aches, they are the default reach for millions of people, and they interact with amlodipine through a mechanism that is almost never discussed when either medication is prescribed or purchased. NSAIDs work by inhibiting the production of prostaglandins. Prostaglandins perform multiple roles in the body, including two that are directly relevant to blood pressure control. First, they influence how the kidneys handle sodium. When prostaglandin production is suppressed by regular NSAID use, the kidneys retain more sodium than they otherwise would. Sodium retention means water retention. More water in the system means higher blood volume. Higher blood volume means higher blood pressure, working directly against everything amlodipine is trying to achieve. Second, prostaglandins contribute to vasodilation in certain vascular beds. Their suppression by NSAIDs can blunt amlodipine's vasodilatory action directly at the arterial wall, reducing its effectiveness at its primary mechanism of action. Research has consistently found that regular NSAID use measurably reduces the blood pressure lowering effectiveness of most antihypertensive medication classes, including calcium channel blockers like amlodipine. The practical consequence of this is something that plays out quietly and invisibly in a large number of patients. Someone on a stable amlodipine dose develops a new knee problem. They begin taking ibuprofen daily for the pain. Over the following weeks, their blood pressure readings creep upward. Their doctor notes the change and considers adjusting the dose. And nobody makes the connection to the over-the-counter tablets being taken for the knee because nobody thought to ask and nobody thought to mention it. Think of it this way. Amlodipine has widened the pipe. Regular NSAID use installs a valve downstream that partially closes it back. The pipe is still wider than it was before the medication, but the downstream pressure in the system is no longer what the medication was designed to produce, because something else is working against it. If you need pain relief regularly and are taking amlodipine, paracetamol is the first-line alternative that does not carry this interaction. If NSAIDs are genuinely necessary for a chronic condition, osteoarthritis, for example, that should be an explicit conversation with your doctor rather than a decision made quietly with an over-the-counter purchase. Topical NSAID gels applied directly to the affected joint deliver far lower systemic concentrations than oral tablets and carry a substantially reduced interaction risk. For localized joint pain specifically, this is worth discussing as an alternative. 4 things down. The fifth is the one that ties every other item on this list together. It is the single most common self-directed amlodipine decision that results in avoidable complications. And it starts with something visible, uncomfortable, and completely understandable. The fifth thing is stopping amlodipine because of ankle swelling without telling anyone. Ankle and lower leg swelling is one of the most frequently reported side effects of amlodipine. It is caused by the same preferential arterial dilation described under thing 3. More blood flowing into the lower limb capillary beds than the venous return can efficiently drain. The swelling is real, it is uncomfortable, it affects how shoes fit, how clothing sits, how legs look in warm weather. It is the kind of thing that feels like a signal that something is wrong, because visible swelling looks wrong, and because the mechanism was never explained at the point of prescription. The entirely reasonable conclusion many people reach is that the swelling means the medication is damaging something, or that it needs to stop. So they stop, quietly, on their own, planning to mention it at the next appointment, which might be weeks or months away. And this is where the fifth thing connects directly back to the second thing, because stopping amlodipine abruptly, for any reason, including ankle swelling, triggers the same rebound vasoconstriction described under thing 2. The arterial smooth muscle that has been held in an extended state contracts sharply. Blood pressure surges, and the person who stopped taking their medication because of a visible, uncomfortable, but manageable side effect has now created an invisible, significantly more dangerous one ADCOS, a blood pressure spike that can arrive within 24 to 48 hours, and that, in adults with cardiovascular risk factors, carries genuine risk of stroke and cardiac events. They stopped the medication because of the swelling they could see. They were not warned about the rebound effect they could not see. This is why thing 5 connects back to all 4 of the others. Grapefruit can make the swelling worse by accumulating amlodipine beyond its intended concentration. Regular NSAIDs can make the blood pressure harder to manage, making the medication feel less effective and more likely to be questioned. Prolonged standing makes the swelling worse and more visible. And when someone stops the medication because the visible side effect finally becomes too much, thing 2 is waiting on the other side. Ankle swelling on amlodipine is common, it is usually manageable, and it is almost never a reason to stop the medication entirely without medical input. There are real alternatives available, dose adjustments, timing changes, additional medications that counteract the fluid shift, but all of them require a conversation rather than a unilateral decision made at home. If you have already stopped amlodipine because of swelling, or if you are currently considering it, call your doctor's office this week. Not at the next routine appointment, this week. Describe what you noticed. Describe what you did. The conversation is simple. The rebound effect is not. 5 things. A fruit you eat without thinking about your medication. A decision to stop that feels like it is putting safety first. A long queue you stand in without moving your legs. A tablet for a sore knee bought at a pharmacy with no prescription required. And a side effect that looks like a reason to stop rather than a reason to call. None of these look dangerous in the moment. That is the entire reason they matter. Each one is the kind of decision most adults make without a second thought, without any sense that their blood pressure medication is involved. But amlodipine works by continuously gradually changing how your arteries behave every single day it is in your system. These 5 things are the 5 ways that continuous relationship gets disrupted without anyone noticing until the disruption produces a symptom. You do not need to become anxious about this medication. Amlodipine is safe, effective, and well tolerated when managed properly. What you need is exactly what this video has given you. The 5 specific things to know, the mechanism behind each one, and what to do instead of each. You now have all 5. One final thing worth knowing. If you are scheduled for any medical procedure that involves fasting beforehand, including dental work, ask specifically how your amlodipine should be managed on that day. Fasting alters hydration status. Combined with amlodipine's vasodilation, reduced hydration can increase the risk of the lightheadedness described under thing 3, particularly if the procedure also involves sitting or lying still for a prolonged period, followed by standing. This is a 5-minute conversation with your care team before the appointment. Have it before the day, not on the day. Which of these 5 things was genuinely new information for you? Leave it in the comments. The responses to that question tell us exactly what is not being covered in prescription conversations, and that matters. Share this with someone who is on amlodipine and has been managing ankle swelling quietly at home, or who drinks grapefruit juice in the morning with their tablets, or who has ever run out of their prescription and waited a few days before getting it refilled without telling anyone. The next video covers 5 things to avoid if you are taking lisinopril, including one interaction that is almost a mirror image of something described here. If lisinopril is part of your routine, you will want to see that one. 5 ordinary things. 1 medication. Now you know all 5.